My name's Alex Goodwin. I'm another clinical coordinator. My background is I'm a consultant in Bath in anaesthesia and intensive care medicine. So this session, the first after lunch, we have to deal with the carbohydrate load that you've just had. So we will endeavour to keep you well and truly interested. We have three excellent speakers, and we're going to be covering a theme that NCPOD uncovers throughout its studies and continues so to do. So we're going to talk about warning signs. A theme runs through all these reports of the early recognition of a sick patient and how you might actually be warned that they are getting sicker. What are the common themes? That we don't recognise the sick or deteriorating patient. That we recognise but do nothing about it. That we recognise but we fail to escalate. And that we recognise in these studies that prevention should be possible. So where have we got these themes from? Well, you have in your packs the yellow covered document listing the common themes, and it really is quite powerful. So the fact that we're not recognising patients comes from the review of 25,408 cases from 17 reports. Now, you say, so why is this? Well, we fail to recognise because we fail to understand necessarily what monitoring is all about. And those of you with a classical education will know that the word monitor comes from manere, to warn or to advise. So our monitoring of patients is essential. And it was recognised certainly in the latter part of the 20th century that patients were dying predictably. And they were dying predictably because when you look back, you could see physiological deterioration that predicted their outcome. Now, as clinicians, for centuries we've recognised this. Galen in AD 173 noted that an irregular pulse was the harbinger of death. So there is someone monitoring a patient and realising that when you monitor them, you can predict what is going to happen. And then in the first part of this century, an early warning system was described by Morgan, Williams and Wright, published in 1997 in Clinical Intensive Care. And they said if you monitor certain physiological parameters, you can then predict what may or may not happen, but equally you can escalate and seek advice and deal and treat and prevent. We've seen a few vignettes at NCPOD. We love using vignettes because it illustrates to everyday clinicians what we're recommending. So, an elderly patient presented to hospital with a 5-day history of severe diarrhoea. Initial physiological observations were blood pressure 95/55, pulse 135, temperature 37.9. There was no record of respiratory rate or urine output. There was no record of an assessment of volemic status. Over the next 48 hours, observations were repeated 8 times, so that's 6 hourly, and revealed persistent hypotension, tachycardia, and on the 4 occasions, so that's 12 hourly, where it was measured tachypnea. No urinary catheter was inserted. Biochemistry performed 48 hours after admission showed urea 33 millimoles per litre, creatinine 455 micromoles per litre, and a severe metabolic acidosis. Despite eventual escalation of care to include critical care admission and renal replacement therapy, the patient did not recover. It's not surprising that the reviewers on that study felt that there were long delays in the recognition of the signs of acute illness that prevented the provision of timely and appropriate care. And they said that the use of a national early warning score may have prevented these delays. Now, NICE in the early part of this century produced CG50 saying that we needed an early warning score. Now what was interesting, if when you look at this, when they were justifying this guideline, this showed where NCPOD actually provided support for this advance in the monitoring of patients. And they said to improve patient safety by addressing the shortcomings identified in the NCPOD report 2005, that acutely ill patients in hospital receive suboptimal care. They wanted to ensure early identification of the acutely ill patient and prevent further deterioration. They wanted to reduce patient mortality, morbidity, length of stay. And they wanted to reduce ICU admissions and readmission. So, recognising that patients become ill is a theme that goes through all NCPOD reports, and the failure to do it properly is another theme. So, the surveillance report on this guideline, some 9 years later, said they won't update the guideline because they felt there was no further evidence at that time. But I think we all know that nothing's perfect, things evolve, and the early warning scores will get better. So going back to these common themes, recognising but not responding, how have we made recommendations on that front? Recognising but not escalating, and preventing if possible. Well, yet again, nearly 13,000 cases, 11 reports. We've recommended that critical care outreach be present 24/7. So that would be part of the recognition and responding. Consultant-led discussion should occur about the appropriateness or not of escalation of treatment. So that's about the seniority. And the close liaison between medical, surgical and CCU teams are important to discuss and appropriately treat patients. Now, subsequent to the publication of the common themes, last Thursday we published 2 more reports. The first was on perioperative diabetes, it's been mentioned already, and what is intriguing is that it comes up. We're recommending that blood sugar measurement should be included in early warning scores. So we're still making those sort of recommendations. The other report published last Thursday, the 13th of December, was on the right course, mentioned again this morning. What was good about this, and we do identify good areas of practice. I think we shouldn't forget that. Well, 91% of patients actually had vital signs recorded, which when you look back to some of our early reports is a phenomenal improvement. However, one area that we could improve on the themes I've been talking about, only 37 of the 68 was there any evidence of a discussion between a referrer to intensive care and the intensivist that was receiving the referral about the appropriateness of critical care. So the themes remain about the appropriate discussion and the appropriate escalation of care. So throughout our studies we have a theme of poor recognition and poor warning of deteriorating patients to escalate care.